All right, so let's look at this is scenario number 5. All right. We have an 80-year-old Miss Lawson. She's established. She's here for follow-up on her neck pain because it's becoming worse. She also has multiple complaints of functional dyspepsia, reflux, chronic disorder of sensation and movement, and neck pain. All right, so we have 3 views of the spine will be taken today and overread by radiology. Apparently, our radiology is not here. She is out of her Flexeril. We will do 10 milligram 12 tablets, as this has helped without creating too much sleepiness for her in the past. We're looking at our dyspepsia, our possible reflux. We've discussed foods that flare up, and she sometimes uses over-the-counter drugs to see if it would improve initially, and then if not, if this does not improve, we'll use a prescription medication. Education was given to the patient regarding this. She has hypertension. It's elevated today. She'll keep a blood pressure card. She is on losartan at 1/2 tablet daily. He's asked her to restart that and go to a full tab, which as she went to a full tab and felt shaky, so she'll restart this medication, but she'll reduce it to 1/2 tablet. All right, so he's telling you to see the health history form, which would be in that patient's chart that we talked about, but basically there's nothing new on it. Review of symptoms, nothing significant for us. Her HEENT is not significant to us. Reproductive, not significant. Menopausal and symptomatic is comments made in the reproductive. The fact that she's 80 years old, she's definitely should be past menopause by then. Physical exam, no abnormalities. I'm looking through each one. Okay. I want to look at the assessment now. Neck pain, X-ray 3 views of the cervical spine was performed in the office today. Flexeril, 10 milligrams, 12 tablets daily. Once the X-ray is back, once he sends it out to that radiologist, and that radiologist bills for it, blessing, like we talked about earlier, then she may have to see a neurosurgeon. We've got dysfunctional dyspepsia going on. We've got medication being reviewed. And her hypertension, she's going to restart her losartan 1-2 tablets daily and keep a blood pressure log. All right, let's look at our walkthrough. All right, this patient was here. We immediately see that she's here for her pain in her neck. And I want to go back, I'm sorry. He gave us a diagnosis of neck pain. Let's go back and look at our diagnosis here. M54.2 is the cervical spine neck pain. So you're not going to code that neck pain additionally because we have a definitive diagnosis. We have other diagnoses that were addressed while the patient was here today. That being her functional dyspepsia, coded to K30, and her hypertension, coded to I10. Now we want to assign our M54.2 as our primary because that's why she's here. So that would be M54.2 would be first. with the other two diagnoses listed in any order. It would not matter, but it does matter on why she's here. All right, so then we want to come down and we want to look at our number of problems. Her neck pain is getting worse. Definitely a moderate, because that's a chronic pain, and she is here because it's worsening. The x-ray of the neck, it was read in the office, but it can't be counted because we're billing for it. So we'd be double dipping. So we come out with a moderate regardless, but let's say that this was a moderate and this was a low. And the only way to get to moderate would be if we counted that x-ray. You can't count the x-ray just to get to a different level, which means a higher reimbursement when you're going to bill for that x-ray. So if you're billing for that x-ray, you cannot count it in your E&M leveling. And we're billing for it. But because we have prescription drug management, we're at 99214. We had two moderates. So we have two CPT codes. Okay, just a minute, Daniel. Two CPT codes, and we got to have a 25. And it's always, the 25 is only on the E&M. Okay, Daniel, you had a question, I think.
Yeah.
Okay.
I want some clarification on the EM service. If you have an established patient returns in a particular encounter, and he has been taking he has been on medication,
Yes.
and then he comes again today. And then if the physician doesn't prescribe drug today or reviews the previous medication, it is not counted for MDM. Am I correct?
I want to repeat what you said to make sure I understand.
Okay.
If he just documents that he's on the medication, but it's not reviewed, no new prescription, no anything, you wouldn't count it. But see, he did today, which you got this correct. I noticed that.
Yeah.
Yeah. But if we go back to this, and there was no medication addressed with the hypertension or the dyspepsia, then no, we would not count it. You cannot count it. I also want to mention that we won't code the menopause. It's not significant. We want to remember in our ICD-10 CM guidelines for chronic conditions, you want to go back and you want to look at your guideline for when to assign. Remember, in the qualification for assigning secondary diagnoses, it must affect the treatment or must be specific. There's specific rules in your ICD-10 CM guideline, but to explain why we choose certain diagnoses and why we don't. And I know that chronic conditions and diagnoses documented within the chart, there's no indication that he treated that, addressed it, or anything. It's just in the body system reviews, reproductive is part of it when you're doing a female physical exam. And the fact that she's menopausal was indicated, it was documented, but it certainly did not create or cause or justify any additional treatment. It's just a diagnosis. It's just a condition he established.
Concerning the data, what we have learned that if the physician is billing for the x-ray it's not going to be part of the, we can't count that while deciding the medical decision. What if it wasn't an x-ray? What if it was maybe a lab test that the physician performed?
Same
And
thing.
Okay, same thing.
I knew what you were going to ask, Leslie. I got ahead of you. I'm sorry. Yes, it's the same thing. Let's go back and let's look at this. Any service for which the professional component is separately reported. And if you'll go back, when you go back and read all this, it will help. But believe me, because this is brand new to me. This just started in 2021. Now, yes, we're 2022, but there's still a lot of things that you have to go back and look at when you're coding. I have to go back and look. So a service is considered anything that you're going to bill for in those CPT codes. So your question of lab, if I bill for that lab, I can't count it over here in my medical decision making. It's double dipping. If I put an 800 code out there for a lab for a urinalysis, I can't go over here and count it in my data. You can only count it one place. And if I'm going to bill for it separately, then I can't count it over here. Because it may contribute to my level. It may raise my level. I can't raise my level when I'm billing for it separately.